The only thing that I didn't double check is which screen I'm sharing, and here is Donna, if you can just confirm if I have the right screen up.
You do.
All right. Good evening. It is August 26, 2020. This is United Medical ACO Diabetes Program Wednesday Wellness webinar. We started these events last week, and this is our second one. Many of you may know by now that we have different providers in our program. My name is Kemal Erkan. I'm the chairman of United Medical ACO. I have Donna Dunkel with me. She's our director of clinical integration. And our program director for our diabetes, accredited diabetes center is Dr. Ripu Handal, who's going to be with us tonight. And also, of course, our program is run by Amy Wilcoxon. She's our dietitian. And then tonight we have Tim McHugh from our physical therapy office, SOS Spine and Orthopedics. And every so often we are going to have Jackie, our licensed social worker, who's going to join with us. So we'll start our program tonight, our presentation, and I have Donna Dunkel going first.
Hi, good evening, everyone. We're glad that you could join us tonight. I just wanted to take a moment just to let all of our patients and anyone listening about some community resources. We know everyone may be going through a lot of different experiences now since we've had COVID. It has affected many people in many different ways. So we do have some resources, and they are posted out on our wellness page. You can see some of them here. If anyone needs any assistance with where they could get food in emergency situations, any pantries and things like that, assistance with low-cost prescriptions, transportation assistance, any other type of social connections and things of that nature. So we do have, as you will see, a couple of screens up here. Kemal, if you could go to the next one. There is a link here. It's called Aunt Bertha. If you go to this link and you put in your zip code, it will then pull up a lot of the different programs that are available in that particular zip code. Our office is located here in Bear. So in that bottom screenshot, you'll see that I had put in 19701. And there are over 1,600 programs in a variety of different categories. You'll see it's anything from food, housing, goods. There's also transportation, health, different things of that nature. So if anyone needs anything, this is a really good general community resource for everyone. And again, it is on our webpage. So we're going to go ahead and jump right into our featured presentation tonight regarding diabetes. So I will turn it over to Amy Wilcoxon to let us know about the agenda for this evening.
Okay, so as we know, today's our Wellness Wednesday. We're going to have Dr. Hundal speak first about diabetes itself, the disease, and then Tim is going to talk about exercise. So if you recall last Wednesday, if you were watching, we're going to have different specialists talk each week. So, and we'll announce what those are on the page, as we know, moving forward for September. So I will go ahead and turn it over to Dr. Hundal.
All right, Dr. Handal, I'm gonna write the mouse here, so if you can tell me when to go next.
All right. Right. Good evening, everyone. I'm Ripu Handal. I work at the First State Endocrinology. That's in Newark, and one other office in Middletown. So I've been managing diabetic population for a long time. Since I've been in Delaware since 2001. Before that, I was at Yale Hospital in New Haven, Connecticut, where I was on the faculty before moving to Delaware. So this is a very important topic, as the type 2 diabetes, or in general, diabetic population is on the rise. And this time, it's thought that there are around 34 million people with diabetes with a prevalence of like 10.5%. So that amounts to 1 out of every 10 person has diabetes, and it's going to go up and up. Out of these 27 million, they have been diagnosed. There are another 7 million people who have undiagnosed diabetes. That means they haven't gone to a physician or haven't been diagnosed. And on top of that, there are 88 million people with pre-diabetes. So that is a stage before, from normal, people go into pre-diabetic range, and then they go into diabetic range. So these are another 88 million population, which roughly amounts to 34% of the total population. So you can put in simple words as 1 out of 3 person has pre-diabetes. Every year, there are 1.5 million new cases being added to this. So what diabetes is, it is defined as blood sugars when your body cannot process the sugars in your body, and it starts rising in the blood. So typically normal blood sugar is defined as less than 100. If it's between 100 to 125, that is in a pre-diabetes or elevated fasting blood sugar. Above 126 by definition is diabetes. And then there is a glucose tolerance test. People sometimes make you go to the lab, make you drink some glucose, where they check your blood sugar before and then 2 hours after the drink. Normal blood sugar should be below 140. Between 140 to 199, 2 hours after that shake, is called pre-diabetes or impaired glucose intolerance. And then above 200 by definition is diabetes. And then we have A1C, hemoglobin A1C, people call it A1C. That is an average of blood sugar control over the last 3 months period. So I will tell you what's the target goal, but that's the A1C. That's everyone with diabetes should know their numbers, so they can tell other physicians whether their blood sugar is in good control or not. So Kemal, if you can go to the first slide. No, back, yeah. So diabetes, what is the classification? There are different type of diabetes. So type 1 diabetes is where there is a autoimmune process where the body develops antibodies which attack their own organs. So they attack the beta cells in the pancreas, which is responsible for making insulin. So these individuals ultimately do not make any insulin. So they are dependent on insulin throughout their life. So they are called type 1 diabetes. Type 2 diabetes, which is the most common type, 90% of the patients have type 2 diabetes. They are making sufficient insulin, but they are resistant to the action of insulin. So initial process, they are making too much of insulin. Insulin levels are very high. Blood sugar stays in a normal range, but ultimately they cannot keep up with the sufficient amount of insulin secretion, and ultimately they develop diabetes. So this is the most common form of type 2 diabetes. And then there are very rare form of diabetes. There can be genetic disorders, or there can be some conditions which can affect the pancreas, which makes insulin, can destroy the pancreas, like pancreatitis. People who drink too much alcohol, alcoholic pancreatitis. Then there's certain drugs which makes people more insulin resistant, like when people go on steroids. That's a very, very common reason for blood sugars going higher. And the last one is called gestational diabetes. This means that person develops diabetes when they are pregnant. So before pregnancy, they were not diagnosed with diabetes. So it's for the first time when someone is diagnosed with diabetes during their pregnancy, is called gestational diabetes. Next slide. So in general, I'm trying to give a rough idea about what diabetes is. So if you have developed diabetes, then what is the current recommendation? How you should, where are your target goals? So in general, as I explained earlier, A1C, that gives us an idea about average blood sugar readings over the last 3 months period. That should be below or around like 7%. So that if somebody tells you, your physician tells you your A1C is around 7.5, that means your blood sugars are running a little higher than normal range, and then our target range. So, but again, it depends upon the age of the individual, what their life expectancy is. If somebody has multiple problems going on, heart failure, has kidney problems, then we usually do not try to have a very intensive treatment, because if we go for intensive treatment, then also comes the risk of low blood sugar, which can be of immediate life-threatening situation for that individual. So when we try to a little bit back off, so every person has their individualized goals as far as A1C is concerned, which you will be talking to your physician, and then between the physician and the patient, then they decide what will be the safest way to bring the blood sugars at target. All right, next one. This is looking at the A1C as I explained, less than 7%. The lower you go, the better it is, provided we are not having too frequent low blood sugar, which is defined as blood sugar below 70. Then if we are checking our blood sugars by finger sticks, then before meals, anywhere from 80 to 130. And if we are checking blood sugar 2 hours after a meal, it should be below 180, preferably below 150 is a better number. So these are the numbers, blood sugar target goals that a patient should look for at home when they're checking their blood sugars. And the A1C, as I explained, is checked every 3 months. If it's above 7%, if it's below 7%, then typically we check it every 6 months. Next one. Nowadays, you must have seen an ad on the TV quite often about the glucose sensor, that where you don't have to prick your finger. So that is the continuous glucose sensor, which people wear on the arms, or there are other like Freestyle Libre you have seen that is worn on the arms. Then there's a Dexcom, then the Medtronic MiniMed, they have their glucose sensor. So when we download the reports from the glucose sensor, it's important to look at is what is called the target range, as shown in this one in green. That is what's your target blood sugar. So again, with the help of your physician, you can set up your goal. Some person may be okay, they are very old, they don't want to have low blood sugar. We may set up target goal of 150 to 200, versus other younger person wants more aggressive control, or during pregnancy, we may set up a goal even lower, from 80 to around 120. So the target range will be set up for different person. So on an average, if the target within target range is typically above 70%, that is thought to be that you are doing a good job in terms of controlling the blood sugars. But obviously, if you see a lot of red bars at the bottom where it's low blood sugar, then obviously we have to intervene and try to make adjustment in the medication to avoid hypoglycemia. So this is just, I want to put it over there for you guys, whosoever is on glucose sensor, that they should look at target range and blood sugars in target range. So that's very important. This can also gives you an overall idea. And then there is one, this called the ambulatory glucose profile, AGP report. So it also gives you an average glucose based on your blood sugars through the glucose sensor. It will also tell you the variability, like how variable some people, the blood sugars can go up and down. If it's more than 36%, that means that person is not at goal. There's something wrong either with their diet or not taking the right dose of the medication. And then the average glucose also gives you glucose management indicator, GMI. So that is 7.6%, which is close to what A1C is. So even without checking a A1C from the lab, you can get this type of information from your glucose sensor readings, and that will help you further to manage your blood sugars in a better way. Next slide. So if you have heard about these topics, like, okay, how we typically manage diabetes, the baseline step, which you will hear more, is the lifestyle, like exercise, weight management. That is a very, very critical step in helping to keep your blood sugars in a good range. It helps to lower your blood pressure, cholesterol numbers get better. So that's a very critical management of treatment of diabetes. Healthy diets, that Amy has talked to you about that. That is a very essential part. Without that, it becomes very, very difficult. So again, make sure if you haven't seen a dietitian, you should see them periodically. They have a great ideas, great way of snacking. Everybody wants to snack here and there. They can teach you how to have a healthy snack and avoid rising your blood sugars. And then increased activity level. The more exercise you do, whatever your body allows, That is also very, very important. It makes your muscles much more sensitive to the effect of insulin and helps to lower the blood sugars. Rather than keep going up and up on the medication, better to do some regular exercise. According to the ADA guidelines, any person with diabetes, I mean, they should be doing at least 30 minutes of exercise 5 days in a week to achieve optimum, at least like 5 to 10% weight loss, which will have a remarkable effect on the blood pressure, blood sugar, and cholesterol numbers. So next slide. Now, diabetes, a lot of people, when we try to put them on medication, they ask us, okay, why are you putting, I have one medication, now you are giving me another medication, should I stop the first one? Or if they are on 2-3 medications and they come to the office still not at target goal, we tell them, okay, you have to add another medication. So just a minute, with this slide, I just want to give you a concept of that diabetes is not just a disease of the pancreas, that if the insulin is not coming, that's why all the problems. There are multiple defects, especially in type 2 diabetes, which majority of the people are on overweight or obese category. They have a lot of things going on in the body, which leads to high blood sugars. So as shown in this slide, in the center is the hyperglycemia, high blood sugars. So here in the top is the pancreas, which makes insulin. So there is decreased pancreatic insulin secretion. And then along with that, with the pancreas, there is increased glucagon secretion, which is a hormone which works opposite to what insulin does. So it helps to raise the blood sugars. Then at the level of the brain, on the right hand side, is that the brain sends a lot of signals to the pancreas, to the other organs, which helps in improving the insulin secretion. So there is some defective brain regulation in terms of this leading to release of these hormones. Then the next one is the muscles. When we do exercise or in general under the effect of the insulin, majority of the glucose after meals is taken up by the muscles. But when the muscles are resistant to the action of insulin, then it doesn't take up that glucose. The glucose stays within the bloodstream. Next one is the fat cells. The fat cells, if they are more insulin resistant, they release more fatty tissue, free fatty acids in the blood, and that leads to further insulin resistance. At the level of the kidneys is supposed to get rid of extra glucose in the urine, but when someone develops diabetes, actually it starts reabsorbing a lot of glucose back into the system, and that leads to high blood sugars. Then the next organ is the liver. When we are not eating during overnight, our brain needs glucose, so that comes from the liver. During daytime, it stores the glucose in form of glycogen, and then during the nighttime or when we are starving, we are not eating, it releases glucose to provide all the energy substrate to the brain. People with diabetes, the liver constantly keeps on pouring out extra glucose. So even if they are not eating, that's the frequent question people ask with diabetes is, I'm not eating and why my blood sugars are going higher? That is because the liver makes too much glucose. And the last part is the gut. There are a lot of hormones comes from the gut, which helps to improve the insulin secretion, helps to decrease the satiety. These are called incretin hormones. So in people with diabetes, these hormones are deficient. So that leads to impaired insulin secretion and increased glucagon secretion. So at least these are like at least different 8 organs they have been described so far, which leads to ultimately high blood sugars in the blood and then more spillage of glucose in the urine. Next slide. So there are one back. So this is where I will later on we will have more discussion about different drugs. But just want to quickly say, I mean, that's why we have so many medications on the market nowadays, because these medications work at different organs. So they have a complementary action to each other to help lower the blood sugars. So the few of them you listed over there, metformin, there is insulin, works on the pancreas. Then we have these more important ones called the SGLT2 inhibitors. You must have heard about the name of Jardiance, Invokana, Farxiga. They belong to that category, working in the kidneys. And then we have these once weekly injection. You see an ad on the TVs like Ozempic, Trulicity. They work on the ingredients in the gut, on the pancreas and the liver to help reduce the weight and help reduce the blood sugars. So you have to use these medication in combination to achieve the best possible target. Next slide. And the last one, I will just put it over there. This is a algorithm put by American Diabetes Association. You don't have to go in detail, but just again, it's telling us now that we have to individualize the therapy. If somebody has diabetes, has heart disease, we may treat them differently. If there is a person with diabetes and they have kidneys problems, certain drugs may be more beneficial in those individuals as compared to other drugs. In some other older individuals, they have risk for low blood sugars, then we may use a different type of medications in those patients. Some of people are very overweight, we use drugs which helps them to reduce weight. And when the last one is the cost is a major factor, then we try to use some generic medications to help improve the blood sugars. So you have to talk to your family physician or whoever is managing your diabetes and try to come up with a plan in which way you safely can lower the blood sugars without causing any hypoglycemia and try to minimize the complications. Just to name a few, just that diabetes is still the 7th leading cause of death. It's the leading cause of end-stage renal disease where people end up on dialysis. It's the leading cause of new blindness. So it affects every part of the system from head to toe, stroke, heart attacks, amputation, erectile dysfunction, you name it. So it can be a very, very complicated disease if you don't treat it on time. So we will have further sessions down the line where we can more elaborate on different medications. But I just want to give a brief overview of what diabetes is, what types of the diabetes are, how we should manage. So one thing very, very important, please work with your family physicians and try to take care of your diabetes very earlier on. Bring it in a better control so you don't develop long-term complications. Pay attention to ABC, that is hemoglobin A1C, blood pressure, and the cholesterol. All these things should be a target goal, and you can live a healthy, long life. Thank you.
All right, Dr. Handal, thank you so much. And we'll have a couple questions in the next couple of minutes, but I think Tim is going to go now, right?
Yeah.
All right, go ahead and hit that button again, Kemal. I think there's some lines that should come up on that slide.
I'm sorry, one more.
Click again. There should be some text that shows up on there. There you go. All right. So as Dr. Hundal said earlier, exercise and being physically active is a piece of managing this. And so we're just going to talk for a few minutes about that. Again, 30 minutes a day, 5 days a week is a good recommendation in terms of exercise. And roughly 150 minutes a week of moderate exercise is what's suggested for this population, both in the pre-diabetic and diabetes population. Has shown to be helpful in terms of managing this. And that 150 minutes per week can kind of look differently depending on everybody's situation. As Dr. Handel said, we want you to be as active as you're able to be. And so we realize that 30 minutes a day at one time might not be possible for you, whether it be because of physical limitations or your schedule. And so even in smaller increments of 10 or 15 minutes at a time, a couple of times a day, where you split that up is helpful. Moderate exercise is usually described as like a brisk walk, right? So if Amy and I are out walking, we should be going at a pretty good pace, but we shouldn't be out of breath. We should be able to carry on a conversation. And so again, it's a little bit subjective because it's going to be different for everybody depending on where they are physically. But it's not running, it's not jogging, it's a brisk walk. If you increase the intensity of that exercise to running or jogging, the minutes per week of exercise decreases, as you see there on the slide. And so the intensity of your exercise is going to directly impact the number of hours recommended of exercise per week. And really, there's not necessarily one exercise that's going to be better than another. Really, whatever you're going to be the most consistent with is going to be the most beneficial, obviously. And so, you know, if there's something you particularly like doing, you know, work that into your schedule so that you can be as active as possible. And even, you know, simple things of tracking and recording your exercise are helpful in terms of being accountable to that, whether it be through an app or whatnot. Counting your steps a day, again, just measuring objectively how active you are throughout the day and throughout the week is helpful with that. With regards to being active, you know, there is a couple things to be aware of. You know, as Dr. Handel said earlier, there is a target range there that's going to vary a little bit from patient to patient with regards to your glucose level, and your timing of activity, and whether or not you need a snack is really dependent on a few different things here. You know, one, certain medications may cause hypoglycemia more than others, and so you need to be aware of what medications those are and whether or not you're on one of those. The timing of when you last ate is gonna impact that. You know, if it's been more than 2 hours or less than 2 hours since your last meal, is gonna affect whether or not you might need a snack prior to exercising. Your pre-activity glucose level is going to be important to know. Again, everybody's target range is a little bit different, and so a safe starting point for you might be different than somebody else. And then if you do need a snack, we need to know how many grams of carbohydrates or what should you eat for a snack prior to activity. And those snacks for you know, pre-activity snacks are going to be different than the snacks that you would take or have when you are in that when you have hypoglycemia or when you're in that situation. So go ahead and advance to our next slide there, Kemal. And again, click there. So how many grams of carbohydrates should you eat if you eat a snack? Go ahead and click one more time there. The general rule is about 10 to 30 grams of carbohydrates per 30 to 45 minutes of exercise. You know, with our diabetes class, we have a chart there that lists out or gives examples of what 15 grams of a carbohydrate snack might be, and what might be appropriate. But generally 15 grams per 30 minutes is going to be your general rule. And so as the length of your exercise increases, you're going to double that if it's 60 minutes, or triple it if it's for an hour and a half. Or if the intensity of the exercise increases, the likelihood of needing a snack might increase as well. But really, a lot of this is going to be driven by your pre-activity glucose level, and what that is and what that target range is for you. And knowing how exercise impacts that glucose level for you is going to be important, because naturally with exercise, that number is going to decrease or drop. And so again, making sure you're in a safe range prior to exercise is going to be important. And again, knowing how exercise is going to impact that number for you is going to be important. So
Tim, I have a question for you. As you know, I do play tennis, so you see a lot of tennis players on TV when right before the match or during the match they eat bananas. So like,
right.
What's that, like the real impact of that? Like how quickly it will be effective for the body?
Amy, you're probably a little bit better equipped to answer that question than I am.
So a half a banana is about 15 grams of carbohydrate. And as we talked about last week, when you eat carbs by themselves, they're quicker to digest. So banana also is a good source of potassium, which your muscles need for exercise. Fruit has a little bit of water in it. I mean, usually with a banana, you should be having some water or Gatorade also, because you need those electrolytes. And certainly people with diabetes on insulin, usually we have them take Gatorade throughout too. And note I said on insulin because of the low blood sugars. But for tennis, especially if it's singles, it's pretty intense. So stopping to have that banana, that 15 grams of carb, it's going to be working in 15 to 30 minutes.
Mm-hmm.
So, does that answer your question?
So sometimes they do say that those players are eating us, so then they intimidate the other side. So just wants to make sure I ask that. Thank you. So Tim, thank you for your part as well. So I know you are part of our accredited diabetes program, and we were doing group sessions in person before, and one of our ways of reaching out to the patients is making these webinars available, and this webinar is recorded and it will be posted for our patients to watch later on. I do have a couple of questions for Dr. Handal. I did prepare my questions not because we were trying to, rehearse it in any way, but there are certain questions that are important for everyone to know. As many of you may know, I also am the chairman of American Surgery Center, which we do have a bariatric program there. On our day-to-day, what I go through with our team, our surgeons and our care coordinators is managing the patient and getting their A1C and TSH scores, the lab values, and based on that, we decide on the procedure. Now, when there was a discussion the other day, patient with A1C 12, and that was not picked up by the primary care physician. I'm assuming that that's if they don't have their routine blood work, annual blood work, so it should be normally picked up. Now, Dr. Handel, what does that mean? Like, what happens if someone has A1C 12 and it was never treated? What is that patient going through day to day if it's not being treated?
Yeah, the A1C again is reflective of blood sugars over the last 3 months period. So average, if somebody has A1C of around 7, that is average blood sugar readings around like 130, 140. When you're talking about A1C of around 12, that is usually around like 250 to almost close to 300 range. So when somebody is having such a high A1C, uncontrolled diabetes, as I explained earlier, most of the glucose is a defense mechanism of the body. When they are not going into the cells, the only way to get rid of that glucose is through the urine. So it usually uncontrolled diabetic individual will be peeing a lot, will be feeling thirsty a lot, because once they get dehydrated, because along with glucose, they pull all the water, essential nutrients, minerals, they are being lost in the urine. So that is the typical symptoms of uncontrolled diabetes, is that they will be feeling thirsty all the time, drinking a lot of water, and they keep on getting up every few hours to pee, constantly pee. And since they're losing a lot of calories in the urine in form of glucose, they start losing weight. So that is a very common symptom. Sometimes people may say, oh yeah, I've been trying my best. Earlier, immediately I lost like 20, 30 pounds. But when you look at their blood sugars, they are still very high. So they lost that 20, 30 pounds because of uncontrolled diabetes. That's a wrong way, unhealthy way of losing weight. And in terms of surgery, when somebody is such a high blood sugars, there's a lot of inflammation going on at the endothelial, at the blood vessel levels. And there are numerous studies which have shown that these individuals are at very high risk of complications post-surgery in form of infection, poor wound healing. So that's why any type of surgical procedures, if it's an elective procedure, your surgeon will ask you to have your diabetes under better control and then get the surgery done. Now, A1C, just to tell from patient point of view, somebody will think, oh, A1C is over the last 3 months. So if I bring my blood sugars down, then this one cannot be checked in next 3 months. So does that mean that I have to wait for 3 months before I get my procedure done? So that's not the case. We have another test called fructosamine. So that fructosamine gives us an idea about the average blood sugar readings over last 2 weeks period. So typically when patient comes to me for surgical clearance, so we will make some intensive changes in their diabetes medication, insulin if we have to do it, and then ask them to send their blood sugar readings. So typically within a couple of weeks, their blood sugars are much better. They are hovering around 150s range. I check that fructosamine level just to confirm, because some people we have encountered that they will falsify their numbers because they want the surgery done. they may say, oh yeah, my blood sugar is around 150, 160. They will send us the blood sugars, but they don't match with the glucose meter. And if we check a fructosamine level, that won't match either. So to be on the safe side from the patient point of view, we usually look at the blood sugars readings and check a fructosamine level. So if the fructosamine level is also in a good range, blood sugars are doing in a good range, we clear them for surgery without the need for A1C. And one last thing, if on the A1C, remember, if somebody has severe form of anemia or they have received recent blood transfusion, then A1C is not reliable. It will give you either falsely high reading or low reading. Some people with thalassemia, they have these rare blood disorders, abnormal hemoglobin, then the A1C is not reliable. So in those patients, you have to look at the individual blood sugar.
Thank you, Dr. Handal. And one other thing, from United Medical ACO, Accountable Care Organization, we are talking to our providers and the insurances. In some cases, what we are looking from what's effective, which medication is more effective, and which of them are more expensive, less expensive. Now there are so many different options, and these are being also advertised as well. What is like? How do we choose the medication for the patient? What's right for the patient?
Yeah, again, now recent guidelines from the American Diabetes Association, American College of Endocrinology, they have emphasized on individualizing the therapy. Earlier, it used to be algorithm, one drug A, then add B, then C, D, like that. But now they've changed it in terms of, okay, what's the underlying condition of the patient? How older they are? Because a lot of these drugs are affected by going through the kidneys. So a lot of these drugs cannot be used if somebody has kidney problems. If somebody has congestive heart failure, we cannot use certain medications. So you have to look at the person who is sitting in front of you, look at their overall health, other comorbidities, what other medical condition they have, then decide which drug will be the best one for you. So as listed on this slide, there are numerous drugs available. Metformin is still one of the oldest one of the safest one available in the market, and that is usually initiated earlier on. And then there are other drugs, sulfonylurea, these are listed over here that they can be used. But again, it's a little bit more longer topic, which we can discuss some other day, but always talk with your family physician. Now, I will just mention just two class of drugs. One is called the GLP-1 receptor agonist. These are injectable therapies, but also one of them has come as oral therapy as well. And the other important one is called the SGLT2 inhibitors. These are the two classes of drugs which you will see that they will be used more and more down the line, because a lot of potential benefit from the heart point of view and from the kidneys point of view. The number one reason person with diabetes dies from is cardiovascular disease. So that's what the emphasis is, to prevent a heart attack, to prevent a stroke, to see if we can delay their progression towards dialysis. These are the things that we are looking forward to, and these are the new drugs which are playing a protective role from these type of complications.
My last question is the weight loss and diabetes. Now, I think every time maybe we have these types of events, I do mention my mom. She has diabetes, so sometimes it's controlled, sometimes it's not. Sometimes she takes her medication, and sometimes she doesn't. So, and she has comorbidities as well. So, weight loss and the diabetes, these are correlated. But one of the, I think, the struggles that I'm hearing these days, especially with the coronavirus being out there, a lot of people are not motivated to leave their home for exercising. And you know, Tim, you cover some of those. Even like personally for me, I try to find excuses not to exercise. So I used to walk more often. Now I'm a little bit less. I used to play more tennis. Now it's a little bit less. So there's always some reason. Now, what would be the best way to get out there and be motivated and just start maybe going back to the normal routine? How can the patient actually go through this time? Any advice for the patients?
The safest exercise, if people also have concerns about going to gym, with some gyms may be very particular about taking all the precautions, some may not be. And then there's people who go to gym also, who are their members. We don't know if the other person, you may be very careful, but the next person exercising next to you, he won't care. He will just do what he wants, he or she wants to do it. So again, a lot of people, patients which I talk to, they are still not willing to go to the gym because of these reasons. And as we know, diabetes can lead to more complications from COVID-19. So if somebody gets it, and especially they are under poor control, that carries very high mortality. So a lot of patients with diabetes are afraid to go out and do a gym exercise. So usually I tell them the safest exercise will be walking. As Tim pointed out, I mean, just like brisk walking, that's the safest one for your legs, for any knee joint, any problems. I just tell them, and if there's somebody out, they said, oh, some people have said, oh, there are a lot of people on the street, so I don't want to go with them. I said, you can put a mask on it. You don't have to wear all the time. When you are close proximity to 3-4 people, just close together, just pull it on your face and go through them. Other times, you can, if you feel suffocated, just pull it down and keep up with your exercise. But exercise is a must. I mean, there's no solution. Majority of my patients, unfortunately, with this COVID have gained weight. So we have started calling them, oh yeah, this is the COVID weight that you have been gaining. And their blood pressure has gone up, cholesterol has gone up, diabetes has got worse. And a lot of people neglected their care. They postponed their visit by so many months. And now I'm seeing them, and now everything is worse. So I think we just have to, every individual, every physician, whichever specialty they are, primary care, I think we have to encourage our patient that, yeah, if you keep on making excuses, then there's no solution for it. I think everyone has to make efforts to try to do minimum exercise, whatever they can. You can do exercise even at home. Nowadays, if you see on the YouTube and other things, you put like a exercise, there's so many exercises now propped up by they saying, oh, you don't need a gym, you don't need dumbbells, bells, you can just do exercise just with hands, and there are a lot of exercise if you want to do it. Again, you have to make efforts to click on the computer and find out those apps and do your exercise.
And I think, again, like you said, Kemal, if you're waiting to feel like you want to exercise, it's unlikely that you're going to feel like you want to. So you just need to build it into your schedule and make it part of your day. And once you get in the routine of it, then hopefully it starts to get easier. But you just need to schedule it into your day, just like anything else, to get started. And then once you get in that routine, hopefully it gets easier.
And I'd like to chime in. My big tip that I tell patients, and that I do myself too, is to make a chart or a calendar and put it on your refrigerator, so you have to look at it every day and either write what you're going to do so you can check it off, or write what you do, because then you have to see those blank spaces that you didn't exercise, and you might feel guilty. And then you have to plan it, like Tim said, so it is actually save time if you have to get up early, so you can actually get it done.
And I think to Amy's point, the more specific you are about what you're going to do, the more likely you are to do it as well.
The other things I tell them to is that maybe just at your home, just do chores at home, like do some vacuum cleaner. That's an exercise. If you keep on going through room to room, I mean, loading a dishwasher, just make some effort. This is some exercise, bending down, putting this, putting that. So again, you can give them a lot of examples that they can just, main thing is to move your muscles.
Well, this was very helpful, at least even from my side. I see this as learning opportunity for us as well. And we want to make this available for our patients so they can benefit from this. We have telemedicine as our primary tool for all of our visits. We are available for our patients, but just to add more to that, we are doing these events. Please take advantage of these and communicate with us. We are here to help. Dr. Handal, thank you so much for being part of it, and Tim, you as well. I think this is one big team that we have. There are different specialties who are part of it, and we'll try to host different providers every time we have these events. Now, Amy, I was going to ask you, when is our next event? I don't know if that's scheduled already.
So we have not scheduled it yet. So we'll be announcing that on social media and sending out messages. It'll be sometime in September.
Okay, and then tomorrow we have a meeting, so we can probably post it at the tomorrow's meeting. But I do thank everyone. I know it's late and everyone is available for us, and even people either they're listening right now or watching right now, or they will be watching these later on. And I feel much better by making these things available for our patient population. Amy, I know you put a lot of time, Donna, you as well. Thank you again, and we'll see you next time. Thank you.
Thank you very much.
Thank you.
Thank you.
Bye-bye.